Your turn now. So we have next Dr. Suryasnata, who will be presenting the keynote for this session for his 2017 award on ocular pathology. The title of his talk is Time Domain Anterior Segment Optical Coherence Tomography in Ocular Surface Squamous Neoplasia.
A very good morning and thank you. So this was what was presented last year. How do you advance here?
Please reset the timer to 10 minutes.
Thank you. Thank you. So I'll go ahead. Now, the management strategies in ocular surface squamous neoplasia has seen a paradigm shift from primarily surgery to either topical or intralesional or subconjunctival, whatever you may call it, immunotherapy to chemotherapy. And there is a need to look at what intrinsically the lesion is all about. Now, if you want to do that, you need histopathology, which remains the gold standard. Is there an alternative? Let's look at a case. Now, this was a lady, 65-year-old, presented with 2 lesions which were non-contiguous. One of them on the palpebral conjunctiva as you see it, and one on the tarsal conjunctiva. Now, there was no lymphadenopathy. Now, this was multifocal. We subjected this to a time domain anterosegment OCT. And look at what you see. So what you see is what has been the previously described characteristics of a hyperreflectivity, primarily epithelial, and then there is an abrupt transition. This has been talked about. But a similar thing has also been seen on the tarsal conjunctiva when we did an ant. But in addition to that, there was a clear plane of separation shown in the white arrow, and there was a basal membrane which was hyperreflective that was also there. This patient came out to be intraepithelial neoplasia. God is thinking that is there a possibility that this could be an alternative to look at what the real histopathology is, and that's what the paper's primary objective was. We also wanted to have a little an audacious goal to try and find out, can we differentiate intraepithelial neoplasia from invasive neoplasia, and finally, does it have a role in surveillance of the lesion in patients who undergo only immunotherapy or chemotherapy. And these were all patients, were consecutive patients. We also had a benign lesions like pterygia to compare. And patients who refused consent and presented only for surgery were taken out. Now, this was between the time period 2014 to 16. Now, this was a lesion that presented, again, characteristics we talk about, a clear plane of separation seen. And this corresponded on histopathology to a faulty maturational sequence. Again, a clear plane present, and this was severe dysplasia. We compared it with several patients who had pterygium. Look at it. It doesn't have the thickening. The hyperreflectivity is there and seems to be subepithelial, though that's difficult in a time domain with its limitation of resolution. Now, when we look at this lesion, this had all the characteristics that you would otherwise put it as an OSSN, and you have the clear plane of separation, but there is a focal breach. Interestingly, on histopathology, there was a focal invasiveness that was seen, and that was reported by the pathologist. So there was something going on. The clear plane seemed to be giving us a sort of a clue about the possibility of invasiveness. Now, this was all patients who had severe dysplasia, and this is what I alluded to, a focal absence of the clear plane, and this was focally invasive. Another lesion where you seem to see that you don't see a very clear plane here, and what the pathologist tells me, this actually showed actinic changes, and these kind of changes seem to correspond to the absence of the clear plane even in an intraepithelial lesion. And that's the histopathology, and that shows the actinic changes. We had 3 patients who had intraepithelial carcinoma in situ, as you call it, and 2 patients with actinic keratosis. Everybody who had a CIS had a presence of the clear plane, and some had the basal membrane too, and this was absent in actinic group. Another lesion where we see the clear plane and the basal membrane there, and the absence was probably in some zones could be related to the possibility of actinic changes that were seen on histopathology. Now, this was an invasive lesion seen as a large lesion, as you can see it here, and in addition to the other changes that we talked about, there were these hyporeflective zones in between, and these corresponded to the stromal pockets. Unfortunately, this does not correspond to an invasive thing, but this was seen across and several patients who had invasive lesions. We had 6 patients who had invasive, and this hyporeflective changes were seen in several. And the big thing, of course, was that the mean thickness of these lesions was significantly high compared to the others. A leukoplakic lesion, and here the dense shadowing that you see did not allow resolutions beyond a certain. So that was a limitation. In leukoplakic lesions, it becomes difficult to get good imaging characteristics. Finally, this patient was a young adult, immunocompetent, and here he did not agree for surgery. We kept him continuously on topical immunotherapy. And look at the ASOCT done nasally and inferiorly. And look at the sequence of changes as it happens over a period of several months of immunotherapy, and the significantly improvement that is also documented and corroborated on the ASOCT. So it helped us not only, there was a little bit of a nasal thickening that remained, and this underwent surgery to show it was dysplasia. So it was helping us in surveillance too. To sum it up, the ultra high resolution anthro-segment OCT has already been talked about a lot. What we were using is a time domain, lower resolution OSOCT, and tended to show all the characteristics that has been talked about earlier to differentiate OSSN from pterygia. But the clear plane was a new thing, and in some layers, the basal layer, which was hyperreflective, that seems to be suggesting, with the limited numbers that we have, about intraepithelial neoplasia, and this was absent in actinic keratosis. The thickness and the clear plane may help us and appear promise in differentiating intraepithelial from invasive OSSN. And finally, it does have a role in surveillance when you're treating the patient not with surgery but completely with immunotherapy or chemotherapy.